Ladies and gentlemen, I am very grateful to be invited at the virtual Endo 24. And I am very pleased to speak about the surgery versus first-line ART in women with colorectal endometriosis and pregnancy wish. So we'll focus patients with colorectal endometriosis because we have numerous data in this specific localization of the deep endometriosis. So as you know, to date, we do not have a randomized control trial comparing the first-line ART to first-line surgery. Thus, we are not able to provide a strong recommendation about the best way to conceive. And it does not mean that women should have IVF just because there is no randomized trial, providing that the surgery works better. So let's have a look at what is happened in the daily practice. So in the daily practice, you know that young women used to stop the pill in order to get pregnant. And in a majority of them, at that moment, there is dysmenorrhea, dyspareunia, and defecation pain, requiring an imaging assessment which reveals a colorectal endometriosis. So the patient has attempted natural conception for only a couple of months, less than 1 year. So in a majority of cases, these women are not infertile because the infertility is not documented. They have not tried to get pregnant more than 1 year, and the infertility is obvious only in patients with bilateral hydrosalpinx. So let's see what has happened if, in the literature, if the patient is referred first to the ART or first to the IVF. So about the data in women undergoing first-line ART, we have two studies, two prospective studies. One coming from the Tenon Hospital in Paris, where 75 infertile patients with colorectal endometriosis underwent IVF. And after 3 cycles, it has been estimated that 69% of them could be pregnant. However, actually, only 43% of them actually conceived until the end of the study. So somehow similar results have recently been published by the team of Cochin Hospital in Paris in 101 women with colorectal endometriosis who had up to 4 IVF cycles. And it has been estimated that after 4 cycles, the cumulative pregnancy rate would reach 73%, and the take-home baby rate would be 64%. And please observe in both studies that performing a third IVF after a second IVF may increase the pregnancy rate by about 10%. Now, let's see what's happened if the patient has a first-line surgery. So in this case, we may have a look at the randomized trial ENDOR, where 37 women with pregnancy intention had surgery for colorectal endometriosis. And we followed them up for 4 years. And we observed that in the overall population, the pregnancy rate was 81%. A majority of conceptions were spontaneous, and 63% of patients actually were infertile. And if we had a look at only patients with infertility, you observe that 74% of them were pregnant, and the majority of them were natural conception. So the pregnancy rate is similar with those reported by after the first-line ART, but a majority of conceptions are natural. So if you want to compare now in the same study, the primary IVF to primary surgery, we have two studies in this way. First comes from Sao Paulo, the study of Bianchi, where patients with colorectal rectovaginal endometriosis were asked to choose between surgery or IVF. And the authors compared the woman with first-line IVF to women to surgery followed by IVF. And they observed that the rate of pregnancy was significantly higher in the arm of first-line surgery. And the same data were reported by our team in 110 patients with colorectal endometriosis using a propensity score. And we observed that women managed by surgery before IVF had better pregnancy rate than women with only IVF. And the results were better in young women with normal AMH and without severe adenomyosis. Now, the colleagues who propose first-line IVF instead of the surgery argue that the surgery is risky and may be followed by complications. And we agree with them. Of course, the surgery of colorectal endometriosis may lead to complication, and the most terrible of them is the rectovaginal fistula. However, the rectovaginal fistula rate is about 3%. And this 3% should be put in the balance with the benefit of the surgery, the high postoperative pregnancy rate with a majority of conceptions natural, with a long-term improvement in pain and quality of life, and low rate of colorectal recurrences. So I think that this balance favors the surgery, the benefits of the surgery. Now we can put the question differently. We can inquire whether or not postponing the surgery in order to perform 1, 2, 3, or 4 IVF is always safe. And just because we recently published a paper where we compared the MRI in patients with no surgery and with colorectal endometriosis, and we observed that after 3 years, 40% of them had an obvious growth of the colorectal nodules, and particularly women without amenorrhea, because they tried to get pregnant during this interval. And if a nodule increased, it may lead to complications without the surgery, complications such as occlusion, kidney loss, vaginal infiltration with bladder dysfunction, and neuropathic pain. And we also showed that if the surgery is performed in deep endometriosis without colorectal involvement, meaning earlier, the rate of complication is very low. Furthermore, you may have a look at this frozen pelvis, where our colleagues involved in aortic should put a needle to retrieve follicles. And you can see that this oocyte retrieval may be safer once the frozen pelvis was removed by a surgery of colorectal endometriosis. Now, the take-home message is that in infertile women with colorectal endometriosis, the ART is followed by good IVF-related pregnancy rate. But also surgery is followed by good pregnancy rate, either by natural conception or IVF. The proper surgery does not decrease postoperative ART rate. And furthermore, the surgery relieves the pain, improves the quality of life at long term. And my advice is, if someone decides the first line IVF, it is reasonable to perform a complete endometriosis assessment and to discuss to present the folder, the medical chart, in a multidisciplinary meeting involving an experienced surgeon of endometriosis. So thank you very much, and I'm very pleased to invite you in December at the 6th European Endometriosis Congress in Bordeaux. Have a very nice meeting.
Many thanks to Professor Horace about this important topic, because it's a lot of discussion, treating extensive in case of pregnancy wish. And we go ahead with the next speaker.